Bismillahirrahmanirrahim. Welcome to the channel. We will start with the routes of spread for the carcinoma of the larynx. We have already discussed its pathophysiology and involvement of subsites in part 1. The link for that is there in the description, so you can check it out there. So let's start today's discussion. Please subscribe the channel so that you are not going to miss any succeeding videos. So most common route of spread is local extension, and as we know that the laryngeal framework is mainly consists of cartilages. So there will be spread to the cartilage leading to the sclerosis, and then additional growth of the tumor will cause cartilage erosion, and ultimately there will be destruction and penetration of the cartilages, and the growth or the tumor will spread to the structures adjacent to the larynx. Then there can be lymphatic spread, but this will depends upon the origin of the primary site, because in part 1 we saw that the glottic region is a watershed, that there is no direct lymphatic spread for the glottic region. So from glottic region the lymphatic spread only will be there when it has already been in at advanced stage and involved the supraglottis or glottis. Then another route of spread of these tumors or malignancies in the body is hematogenous spread. Same is the case here, and from here the tumor can spread via blood to the bones and followed by in the lungs. So this is the pattern of lymphatic spread, and as you can see, the supraglottic carcinoma is more prone to lymphatic spread. So 44% means almost half of the patients at the time of presentation in case of supraglottic growth will be having a lymph node metastasis. In contrast, the glottic carcinoma or subglottic carcinoma, they spread at a very advanced or later stages of the disease, only in 5 or 6% of the cases. These are different lymph node levels in the cervical region. There is a level 1 which contains the submental and submandibular lymph nodes, then upper, middle and lower deep cervical lymph nodes. Posterior triangular lymph node is level 5. In the midline, prelaryngeal and pretracheal and paratracheal lymph nodes, they are included in level 6, and level 7 is the, of course, is the mediastinal lymph nodes. So this is the spread of supraglottic growth in different stages, because as the disease advances, there are more chances of local and lymphatic spread of the disease. The clinical manifestations or the features or the symptoms, they will depend upon, of course, the site of the tumor, and glottic carcinoma is the most common tumor, and whenever the true vocal cords are involved by any lesion, immediately there will be hoarseness or some change of voice. Patient will be feeling dysphonia or hoarseness. So same is the case here. So the primary symptom will be voice change. Then there can be other symptoms like hemoptysis, dyspnea, respiratory obstruction, dysphagia, weight loss, or even in later stages there can be pain, but it will depend upon the extent and size of the tumor. In contrast, the glottic carcinoma, which attracts the attention of the patient and he seeks the medical advice at the earliest due to change in voice. The supraglottic growth patients, they present late because initially they are having very vague symptoms. We know, for example, if there is a small ulcerative lesion over the epiglottis, the patient may be feeling, for example, sore throat, or there may be pain in the throat which is referred to the ear, or some foreign body sensation, so which may be missed by the clinician, and they may consider it like routine pharyngitis or some acid reflux like that. So this is the reason the patient is diagnosed or presenting to the ENT surgeons at a later stage in case of supraglottic growth. Along with these symptoms, there can be aspiration on swallowing, dysphagia, and 50% of the cases they may present with the lump neck because of lymph node metastasis in case of supraglottic growth. Then hemoptysis or dyspnea can also be there. In subglottic region, there will be, if a mass, depending upon the size of the mass, airway obstruction, then dysphagia, weight loss, or hemoptysis can be there. So, detailed history and clinical examination along with endoscopies is must, and if some mass is suspicious, biopsy should be taken, and CT and MRI can be done to see the extent of the tumor, which will be helpful in staging of the disease if it turns out to be a malignancy, and barium swallow if it is indicated. This CT scan, particular CT scan, showing us a huge mass there in the supraglottic region. So diagnosis and clinical staging depends upon the findings on history, clinical examination, radiological imaging, and lab tests. While pathological staging, it will depend upon the findings from the surgical resection and its histological examination, that whether it is well differentiated or moderately differentiated or poorly differentiated squamous cell carcinoma. The American Joint Committee on Cancer has devised a TNM classification in which T stands for primary tumor, N is for lymph node metastasis, and M is for distant metastasis, and all this helps us in staging of the disease. So T primary tumor, Tx is when primary tumor cannot be assessed, T0 is when there is no evidence of primary tumor, and TIS is when there is carcinoma in situ. After that, in a supraglottic region, T1 is when tumor is limited to one subsite of supraglottis. We know that supraglottis consists of epiglottis, aryepiglottic folds, arytenoids, then there are false cords, then there is ventricles. So if any one subsite is involved and vocal cord mobility is normal, it is T1. When tumor is involving more than one adjacent subsites of the supraglottis, or even in glottic carcinoma, the glottis, without fixation of the larynx. Without fixation of the larynx, we call it as T2. For example, the tumor at the root of the epiglottis, and along with that it is involving the aryepiglottic folds, or there is a small lesion over the false vocal cords and it is involving the underlying ventricle as well. So more than one adjacent subsite of the supraglottis is involved, but still the vocal cord mobility is fine, then we will label it as T2. While T3 is when tumor is limited to the larynx, that tumor has not gone beyond the confines of the larynx, but vocal cord has become fixed, or the tumor has invades the postcricoid area, pre-epiglottic space, or the inner cortex of the thyroid cartilage. Still, outer cortex of the thyroid cartilage is intact, but inner cortex of the thyroid cartilage is eroded. We will label it as T3. Moderately advanced local disease is when tumor is invading the thyroid cartilage. Now, inner cortex and outer cortex both have been involved or eroded, and that tumor has gone beyond the confines involving the pre-laryngeal tissues. Then the tumor is at stage of T4A. And T4B, of course, it is very advanced local disease when it is involving the prevertebral space posteriorly, laterally to the carotid arteries, or inferiorly it has gone into the mediastinum to involve the mediastinal structures. The disease is at T4B stage. In glottic carcinoma, the T1 is when tumor is limited to one vocal cord with normal mobility. T1B is when tumor is involving both vocal cords but still there is normal mobility. T2 is when tumor is extending to the supraglottis or subglottis with impaired vocal cord mobility. That vocal cord is not fully fixed, still some mobility is there, then it is T2. But when the tumor has limited the vocal cord mobility and vocal cords have become fixed fully, or it is involving the paraglottic space, or just like supraglottic growth, only the inner cortex of the thyroid cartilage, then we call it as T3. But once not only the inner cortex but outer cortex of the thyroid cartilage is eroded, and the tumor has come into the pre-laryngeal tissues, then we call it as T4A. And T4B is, of course, when it has gone in the mediastinum or it is involving the prevertebral space. So locally very, very advanced tumor, then we label it as T4B. In subglottis region, T1 is when tumor is limited to the subglottis. T2 is when it extends upwards to involve the vocal cords, but still the vocal cord mobility, either it is normal or it is impaired, but not fully fixed. T3 is when this tumor arising from the subglottis, it has involved the vocal cords and there is vocal cord fixation, complete loss of its mobility, then we call it as T3. And T4A is again moderately advanced local disease which is invading this time not the cricoid but also the thyroid cartilage or tissues around the larynx, then it is T4A. And T4B is very advanced local disease invading the prevertebral space or carotid artery or mediastinal structures. Then is the lymph node metastasis. N stands for lymph node metastasis, and this lymph node metastasis, a classification, is the same which is there for hypopharyngeal carcinomas or oropharyngeal carcinomas or oral cavity cancers. So same is applies everywhere. Nx is when we cannot assess the tumor. N0 is when there is no lymph node metastasis. N1 is when metastasis in a single ipsilateral lymph node which is less than 3 centimeter in its greatest dimension. So single ipsilateral lymph node which is less than 3 centimeter. N2A is that metastasis, again there is only a single ipsilateral lymph node, but this time it is more than 3 centimeter, but still it is less than 6 centimeter. So single ipsilateral lymph node from 3 to 6 centimeter, it is N2A. If metastasis is there in multiple ipsilateral lymph nodes, for example, on the same site, the lymph nodes are 2 or 3 or 4, they may be even 1 centimeter or 1.5 centimeter or 2 centimeter or 4 centimeter or 5.9 centimeter, it will be N2B. None of these lymph nodes should be more than 6 centimeter. So N2B means from 0 to 6 centimeter dimension, multiple lymph nodes on the same site, on the ipsilateral side. And N2C is when metastasis in bilateral or contralateral lymph nodes more than 6 centimeter. So again, the size may be 1 centimeter, 0.5 centimeter, or it may be 5.9 centimeter or 5.99 centimeter. But the lymph nodes now, either they are bilateral or only a single lymph node may be contralaterally present. Contralaterally present, then we will label it as N2C. And N3 is that any lymph node, either it is single or multiple, ipsilateral or bilateral or contralateral. If the size of any of the lymph nodes is more than 6 centimeter, straightforward, the stage of lymph node metastasis will be N3. Distant metastasis, again MX is when distant metastasis cannot be assessed, M0 is no distant metastasis, and M1 is distant metastasis. And staging will be depending upon all these factors, that T factor, N factor and M factor. So whatever the T may be or N may be, if it is a distant metastasis is present, straightforward the stage will be 4C. So M1, it is stage 4C, T may be T1, it may be T4, it may be T3, similarly N may be N1 or even N may be N0, it may be N2 or N3, the stage will be for stage 4C. So at stage 0, there is carcinoma in situ and of course N0 and M0. Stage 1 is T1, N0, M0. Stage 2 is T2, N0, M0. Stage 3, either tumor is locally advanced, that is T3, but still N0, M0, or tumor is not locally that advanced. It is still T1 or T2, but regional lymph nodes are involved. So N1 is there and still M0. It is stage 3. And the tumor is locally advanced, that is T3, and lymph node metastasis is there, N1, and still M0, it is stage 3. In stage 4A, if the tumor is locally very advanced, that is T4, but still there is no lymph node metastasis, no distant metastasis, it is stage 4A. And stage 4B is any T with advanced lymph node metastasis, that is N2 or N3, and still M0 is there. And stage 4C, as I told you, it is a distant metastasis. Whatever N may be, whatever the T may be, the disease has already spread too far and advanced it is, so that's why it is labeled as stage 4C. And histological grades, as I told you, it will depend upon histopathological findings of surgical resection of the tumor or the biopsy, and the histopathologist will label it as well differentiated. Grade 1, grade 2 will be moderately differentiated, and grade 3 will be poorly differentiated carcinoma. So with that, we come to end of this session. In next video, we will chalk out the plan, management plan, or the treatment for these patients in different stages of the disease. So please share and subscribe the channel, and thanks for watching.